Good afternoon, everyone. Good afternoon. I'm John Walsh, President and CEO of UGI Corporation and also Chair of the World Affairs Council. As Chair of the World Affairs Council, I have a really important job. Those of you who've attended events like this know that I am the head shusher. So you put somebody up here who it doesn't really matter what they're saying, but you sort of quiet the crowd. So the people that are going to say things of substance have a sort of a nice quiet room. So I'm fulfilling my head shusher role here, and also have a couple of other critical announcements to make. First of all, thank you all for joining us today in this most appropriate venue for our Great Debate Series program on the American healthcare system. The Council is thrilled to have partnered with the Thomas Jefferson University Hospitals as well as Independence Blue Cross to present this timely conference in this great venue. Before we begin, I'd like to take a moment to ask everyone to silence their cell phones and other electronic devices. However, we encourage you to like us, the World Affairs Council, on Facebook and to live tweet with us today using hashtag GreatDebatesHealthcare. That's all one word for you tweeters. And now it is my pleasure to introduce Dr. Stephen Klasko, President of Thomas Jefferson University and President and CEO of Thomas Jefferson University Hospitals. Dr. Klasko.
Thank you, John. It is my great pleasure on behalf of Thomas Jefferson University and Hospital System, the World Affairs Council, and Independence Blue Cross to welcome you all here for this conference, In Sickness and in Health, American Healthcare in the Age of Obamacare. You know, right before I started my job at Jefferson, I was speaking at a Forbes conference, and the person who spoke before me said, the two things you don't want to be leading over the next 3 years, because they're going to be, in his words, impossible, are academics and healthcare. And I said, damn, I just took a job in academic healthcare. But I was comforted by an Adidas marketing ad, which is called Impossible is Nothing. And this is what it said. It says, impossible is just a small word thrown around by small men and women who don't want to do what it takes to do the impossible. Impossible is potential, impossible is nothing. So whatever you think about the Affordable Care Act, it's allowed us the potential to do the impossible, namely break the quality, access, and cost iron triangle that's existed in this country throughout my lifetime. There are many, many moving parts within the ACA, particularly in a year when the expansion of coverage has become a reality. But two things are certain: continued transformation of the healthcare delivery system and the unrelenting focus on deficit reduction at the federal level. As Yogi Berra would say, it all comes down to one word: clinical alignment. Because of these factors, the stakes continue to be very high for us in the healthcare industry, whether you're a payer, a provider, an employer, the government, or most importantly, and the reason that we all have a job, the patient and the consumer. At the same time, the opportunity to foster innovation to reduce costs and improve efficiency, quality, and the overall patient experience is an all-time high. And that's what we do very well in this country. We're sitting here in Philadelphia, arguably one of the country's major cities in healthcare and academics. I'm honored to have been asked to lead a 189-year-old institution that was chosen by U.S. News & World Report as the number 17 hospital system in the country. In fact, many of you might not know this, but we're proud of the fact that Pennsylvania is the only state, along with California, that has 3 hospitals in that elite honor roll. But our trustees, to their credit at Jefferson, have recognized that all that does for us is allow us the potential to innovate. That if we're not fundamentally changing, moving from volume to value, and taking a lead role in initiatives which drive quality and innovation, we will not have a future as optimistic as our past. It's for that reason that we are so pleased to host today's conference. Healthcare affects every American in ways that are passionately personal, because of that, profoundly political. This conference, featuring many of the nation's leading thinkers on healthcare policy, will explore issues ranging from healthcare economics to medical ethics, from issues of health insurance coverage to issues of how we can create faster cures. We are delighted that you can join us for this important set of discussions. I am extremely honored to share the stage today with 3 thought leaders and 3 of my healthcare heroes, Dan Hilferty, Dr. Emanuel, and Leader Frist. And Dan, you're responsible for 2/3 of my revenue, but I have to say that I would have said that anyhow. And Leader Frist and Zeke, I don't owe you anything, but I do believe that. So gentlemen, Audience, welcome to Jefferson. I'm looking forward to a very lively discussion this afternoon. I can promise you that there will be a few surprises, some very vibrant discussion, and that we will all, panel and audience alike, leave here a lot smarter than we entered. Please join me in welcoming the Chairman of the Board and CEO of Amatec and World Affairs Council Vice Chairman, Frank Hermance.
Good afternoon, and thank you, Stephen. Let me take this opportunity again to thank both Jefferson and Independence Blue Cross for their partnership with the World Affairs Council in today's program. I'd also like to take the opportunity to mention that this conference is part of the Council's Great Debate Series, which was made possible by the Stan and Arlene Ginsberg Family Foundation and matching contributions from Amatec, SEI Wealth Management, and UGI Corporation. Today, Council President Greg Snyder, who is in the middle of the table, will moderate this session and the following session, so he's going to be a busy fellow today. So for this opening session, which is focused on Obamacare, Craig is joined by, again, Stephen Klasko, MD, PhD, who is president of Thomas and Jefferson University and president and CEO of the Thomas and Jefferson University Hospitals. The Honorable Bill Frist, MD, former United States Senator and Majority Leader. Emanuel, Vice Provost for Global Initiatives and Chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania. And for those of you who watch Fox News, he seems to be on every night. And I think it's because he likes Megyn Kelly. And also, obviously, Daniel Hilferty, President and CEO of Independence Blue Cross. So let's begin. Craig, it's yours.
Thank you, Frank. We're going to start with opening comments from each of our speakers and then have a kind of somewhat structured discussion. Where are we? We're not live. Okay, let me get close. Let's try now. There we go. Okay, we got to be close. We're going to start with opening remarks from each of our speakers briefly, and then go to the meat of our discussion. I'd like to ask Senator Frist, if he would, to make an opening statement.
Thank you, and it's a great pleasure for me to be here. And I'm going to keep talking because somebody's got the microphone, and see if they can turn this up just a little bit louder. And if you can't turn this up, I'm going to take that microphone.
You just got to get close. You just have to be close, really close.
Okay, he said don't get it any closer than 6 inches. Specific instruction. Let me really open with what is Obamacare, just to go ahead and set the stage. And if you ask yourself as we're sitting here, what is Obamacare? We know that healthcare is about 18% of our GDP, $3 trillion out there. It's grown from 8% to 18% over my lifetime. It's going to keep growing. And then you had what was pulled off by a president of the United States that presidents since Harry Truman have tried to do, and that is to have not comprehensive, but major health care reform. And all presidents had failed until President Obama. And now we have Obamacare. What is it? The easiest way to think about it, it's not even intended to solve all of our health care problems. It is mainly an access bill to lower the barrier for people, specifically those without insurance, to get affordable access to health care. And therefore, when people say, is it going to improve quality, is it going to lower cost, and what's it going to do in terms of prevention, all of that is out there, but that's not the purpose of Obamacare. And the purpose is to take 42 million people without health insurance and hopefully get all of them into an insurance market of some sort. So look at it as an insurance reform that left, right, Republicans, Democrats all agree on, and most of that has already taken place. And then, that's the pre-existing illness, so if you have cancer, you can get insurance. If you're 25, to be able to go on the policy of your parents. If you have what's called medical loss ratio, to make sure the insurance companies are not putting too much money into administration, all that stuff, which is good. We'll hopefully talk about some of that. But then what it really does with 42 million people, said initially it would take 16 of those 42 million and put them in Medicaid. Medicaid is our program allegedly for the poor, but it has huge gaps that most of you probably aren't aware about. If you're a single man, you are not covered by Medicaid in most states today, no matter how poor you are. The point is there are huge gaps. So President Obama said, let's fill those gaps. Let's raise it not just to the poverty level, but take it up to 138% and put 16 million of those people there, and 16 million people in what are called state exchanges or federal exchanges. Exchanges which did not exist 3 months ago anywhere, maybe one state, but didn't exist. And now every state in America has a state or federal exchange. We'll talk more about that. But conceptually, insurance reform, 16 million people in Medicaid, 16 million people in these exchanges. That is to address the access issue. That's the framework we'll keep coming back to. We haven't rehearsed any of this, but we'll keep coming back to, because Medicaid was blown up conceptually by the Supreme Court, who says it's not mandatory. States can decide whether to fix this 16 million, and most states, or half the states, have decided not to plug those gaps. In the exchanges, all of this about how many people have signed up, there's supposed to be 7 million people, 6 million, and 4 million people have signed up for these state exchanges and federal exchanges. Well, there's still 12 million people out there. And then there's this new stuff called a private exchange, not a state exchange, a federal exchange. We'll talk more about that. Let me just close and say, think healthcare services, mostly what we'll be talking about, but also health. Health has lots of determinants to it, how healthy we are as a nation, as individuals. Healthcare and healthcare delivery is actually a very small part of that. Clinton care, Romney care, Obamacare, no matter how good we are, universal health care, all of that, no matter how good we are, there are other issues that we'll talk more about over the next little bit again, but that's health and health of a population and health of a nation, very different than healthcare and healthcare delivery.
Thank you. Zeke?
It's great to be here. Let me, in my 5 minutes, make 3 points. First one is, let's rewind to 2008 and 2009 and just quickly say why we needed healthcare reform and why it actually got passed. On the access problem, we had 50 million Americans without health insurance, most of whom were either working or children or spouses of people who were working. So these were the working poor who just, their employer didn't provide it and they couldn't afford it. Second, we had peaks of great quality of care in this country, but very uneven quality and no guarantee that if you went into the hospital, things would go well. You know, 1 in 20 people getting a hospital-acquired infection and tens of thousands of people dying every year as just one example. And third, we had a cost problem. In 2000, we were spending $1.4 trillion on health care. By 2009, when the president came in, it was $2.5 trillion of health care, and today it's $2.9 trillion of health care. The increase was 84% over that decade in real terms. Unsustainable by anyone's imagination. That's why we needed Obamacare. And you had to have a solution to those 3 problems. What is the result of Obamacare done? And here I will have a minor quibble with the senator, and it really is a minor quibble. The bill is not only an access bill. There's many other parts. It's a 906-page bill, and not 2,000 pages, and of that, 222, I counted them, deal with access. The remaining deal with things like cost, improving that hospital-acquired infections, workforce issues, and other elements, raising money, among other things. There's first, what's it doing on the access side? Well, it is providing a structure, the exchanges, that will allow Americans to go and shop in a marketplace for health insurance broken down into 4 categories. It is an efficient way of delivering health care. Despite the bad rollout of the federal exchange, Many states, individual states, have done a very good job, Connecticut probably being the best, Kentucky, California, New York. This is going to be a platform that I have predicted in my book almost all of us will use by 2025. That's how we're going to get insurance. Second, it has a lot of cost control measures. It reduces prices, excessive prices paid in Medicare, but it also incentivizes changes that are going to be cost savings, experimenting with accountable care organizations, not paying fee-for-service, but paying bundles, having a Cadillac tax. So if you have a super gold-plated health insurance plan, you'll pay over a limit beginning in 2018. That's putting downward price pressure. So there's a lot of cost control in the bill. And the last thing is, has a lot of programs to improve quality. Let me just mention two. First, the Partnership for Patients, begun in 2010 under the Affordable Care Act, targeted these hospital-acquired infections. We've seen dramatic improvements. Drops of 41% on central line infections, 50% on elective C-sections before 39 weeks, 50% drops in respiratory pneumonia related to ventilators. Big improvements that all of us, whether we get Obamacare or not, are going to see if we happen to go into a hospital. Let me conclude with thinking about the future. Where is this going to take us? Well, I'm pretty optimistic, for one thing, on the cost issue. I actually think the Affordable Care Act is going to put unrelenting downward price pressure and force the innovation that you heard about. What are we going to do? We're going to see a real focus on people who are chronically ill, who consume most of the money in the healthcare system. We're going to try to keep them healthy, prevent them from getting sicker. So if they're a diabetic, prevent them from getting having that foot cut expand into gangrene, expand into an amputation. Keep them at home. If they get a sick or an exacerbation, treat them at home so we won't use as much hospital services. It's cheaper, they heal better, and their quality is more consistent. We are going to focus, I think, unrelenting on that, and over the course of the decade, the places that do it well, they're going to cut their costs 20%. So we're going to have real cost pressure and quality improvement at the same time. And the last thing I would say is the insurance companies are going to change pretty dramatically over time. I think the old model is going away. We're going to have a lot more integrated delivery systems, what I have called the Kaiserification of American health insurance. That they are going to begin having providers. Penn is probably going to begin offering insurance. Jefferson would offer insurance in the exchanges into employers. And I think that is going to be a dramatic change over the next decade or so. So I'm actually pretty optimistic about where this framework is taking us, and it does create uncertainty because there's a lot of change, but I think in the end, the result is going to be quite positive for all of us.
Stephen? Well, thank you. So if you walk into my office, the first thing you'll see is a quote from Buckminster Fuller that says, if you really want to change something, don't change the existing reality, create a new model that makes the old model obsolete. If you walk a little further into my office, you'll see a little less elegant quote from Mike Tyson that says, everyone's got a plan until they get punched in the mouth. So here's the scoop. Here's the scoop. As healthcare providers and leaders, we've gotten punched in the mouth, and we can either continue to react to healthcare reform, or we can create new models. So I think that maybe this conference should have been called Forget Reform, Think Transformation. So I'd just like to, in my few minutes, talk about a few things that we have the ability to transform. I think the least talked about issue is changing the DNA of healthcare one physician at a time. Most of my research has been on what makes doctors different than, depending on the audience, either other people or normal people. And the simple fact is the way we select and educate physicians, we've joined a cult around a few biases, an autonomy bias, a competitive bias, and a hierarchical bias that keeps us from being able to embrace this kind of change. So we can react by creating more medical students, or we can transform by recognizing that we still accept students based on science, GPA, MedCats, and organic chemistry grades, and somehow we're amazed that doctors aren't more empathetic, communicative, and creative, as my kids would say, duh, and really change the way that we both select and educate physicians. And that's something that we are starting to do at Jefferson, and also start to look at the folks that are currently practicing and invest a lot of dollars, which is what policymakers and health insurers should help us do in changing the DNA of our medical staffs. Readmissions. We all want to stop readmissions. So we can react by counting and accounting for what happens when those patients leave, or we can transform, like some folks have done, by recognizing that we have family physicians and patient-centered medical homes that never go into the hospital, and then we have hospitalists that are not allowed to leave the hospital. But you can create something called extensivists, where the hospitalists actually follow those patients for 90 days. If you add a little dose of what every other industry is doing, let's say telehealth, where patients can actually have two-way electronic communication with their providers, which we're starting to do here in Jefferson, you can actually totally change that curve around readmissions that just goes beyond the traditional of why did this patient come back. Surgeons today still can go their entire career without getting their teamwork or technical competence assessed. You're a pilot, leader first, I'm a pilot. You have to get your technical competence assessed every couple years. I still operate. The last time anybody checked my technical competence was 1984. So we can, again, react by doing quality committees and learning curves, or we can transform by saying anybody that's going to do robotic surgery in this country has to prove that they're competent, because that technology and those means and standard deviations are there. Every discussion about the new health care talks about the need, or at least a passing allusion to the lack of primary care providers. So we can react by saying, let's create more family practice residencies. But here's another scoop. Nobody wants to go into family practice. Why don't they want to go into family medicine? Because they make 20 to 30% of what their specialist colleagues make. When we started our first patient-centered medical home, I went to my chair of family medicine and said, good news, Jamie, you're going to get to be the quarterback of the system. He said, well, what does that mean? It means you get to tell the vascular surgeons what to do. You got a lot of paperwork. He says, you know, you pay me $150,000 a year. You pay your chair of dermatology 10 times that. Let him be the quarterback. For what I get paid, I'd like to be the kicker, because the kicker doesn't get tackled. So until we start to look at different models, so how can we transform? We can really start to create ACOs, which we've done, where the family docs are really the leaders of a team. We can pay them more. We can have 2,500 patients seen by 5 family physicians and pay them X. Or we can get over ourselves and realize that doctors of nursing practice and nurse practitioners and clinical pharmacists are part of the team, and have one physician lead that, and we can pay that person a lot more. It means the medical societies have to realize there's something more important than saying doctors of nursing practice can't call themselves doctors. It means that we have to look at ourselves as teams. So I guess what I'd conclude with is that we spent the last several years, whether it's healthcare insurers or health leaders, reacting to healthcare reform and the external changes through cost-cutting, planning, and spending dollars, a lot of outside consultants to help us guide the path for readiness for reform. And having been the CEO of a few health systems, this is what happens when you bring in the consultants. It sounds something like this. Given your payer mix, academic needs, and structure, you're doomed. And if you pay me a lot of money, you can be 30% less doomed. I believe that that's true if we keep doing what we're doing, and then that's an accurate assessment. But I would say that for those of us who lead health plans, large hospital systems, physician groups, employers, and policymakers, we need to spend time on how we can use new technologies and processes to fundamentally not react, but transform the healthcare system. And what I like to say, and change the DNA of healthcare beyond some of the incremental approaches that we've been relying on to this point. That's what I'm excited about hearing today.
Great. Thank you. Steve, you've been gone for a few years. Sometimes in Philadelphia, kickers get tackled. Just want you to know. Craig, I'd like to thank you and the World Affairs Council, and John, thank you for having this program today. Independence Blue Cross is really proud of our long relationship with the World Affairs Council. Our president of commercial markets, Chris Cashman, is on the chairman's advisory board. And the chairman of our board is chair emeritus of the council, so we're proud to be here. It's interesting coming last in these introductory remarks, because I kept going, okay, that was said. But just let me summarize. What I heard Senator Frist say very clearly is that there's need for reform. 18, 19, 20% of gross domestic product and growing. And then certainly Dr. Emanuel mentioning that 50, 60 million Americans out of insurance, accessing care from the highest cost emergency rooms and similar types of services. There was time for a change. And then certainly I was so excited to hear Dr. Klasko speak about innovation. And that's where I'd like to give our introductory remarks as an insurer. I think Dr. Ezekiel, Emanuel is absolutely right. Insurance companies have to change, but so do hospitals, so do physicians, so do patients, so do primary care docs and specialists, allied health professionals. Everybody needs to change. And those who don't change will perish, will not be here. We'll see consolidation both in insurers and health systems, other health-like organizations. But here's what you need to know as Independence Blue Cross, a Blue Association insurer, that we have been committed to reform from the very beginning. Sure, we weighed in both on the Republican side, on the Democratic side as the cake was being baked. But once that plan was signed into law, we decided that our job was to make sure that people are insured. We have one of the largest Medicaid managed care entities in the country. In states where it's being expanded, where managed care is becoming more of the model, we're looking to grow in those areas. Where some of our fellow insurers, the large commercials, decided not to play on the state, federal, or joint exchanges, we jumped in with both feet. We have 13 products across in Pennsylvania alone, 13 products across the metallic levels, 30 variations of the products. Our prices are the lowest across the board. Why do we do that? Not because it made business sense, because we, from a mission point of view, from a philosophical point of view, believe that we have a responsibility as an insurer, along with providers, along with policymakers, to get people insured. The proof will be in the pudding, as they say, but we believe it's off to a good start. And when you talk about innovation, it's where I'd like to finish. You think about the Philadelphia area. Thomas Jefferson Health System and University, University of Pennsylvania Health System and University. You look at all the other major health systems. You look at the pharmaceutical companies. You look at the other academic universities. You look at us as an insurer. Philadelphia should be the Silicon Valley of healthcare innovation. We're working with both these organizations to make sure that we put money in a pot to attract the brightest from around the country to come here, develop their ideas, incubate their ideas, to develop them into technologies, into services, into systems that will truly start to give people greater access, drive down cost, and put the innovation in place that we need. I'm sure there's going to be points where I have disagreement here. That's the beauty of this discussion. But again, I look forward to engaging in the dialogue.